Welcome. My name is Maria Castellucci, and I'm a content strategist here at Modern Healthcare. I'll be introducing this webinar, Market Transformation Through Hospital Musculoskeletal Service Line Optimization. In this webinar, we'll discuss how to transform and disrupt the musculoskeletal landscape in your market by improving outcomes, growing market share, and reducing costs. A couple housekeeping notes before we get started. We want this webinar to be an interactive experience for our audience. You're encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will try to address as many of your questions as they have time for. Should you need any assistance during the webinar, please don't hesitate to contact us via the questions pane in your attendee panel. We'd also like to thank the sponsor of this webinar, HOPCo. Healthcare Outcomes Performance Company is the national leader of integrated musculoskeletal value-based health outcomes management and health system service line management. HOPCo's affiliated payors, practices, and health systems successfully participate in highly efficient value-based contracting using HOPCo's proprietary platforms, IT solutions, integrated analytics, and standardized care pathways. It's my pleasure to introduce our speakers for today's webinar. Dr. Wael Barsoum, President and Chief Transformation Officer at Health Outcomes Performance Company, and DeLyle Manwaring, Executive Vice President of Market Transformation at Healthcare Outcomes Performance Company. The floor is yours.
Maria, thank you very much for your kind introduction. On behalf of my colleague and partner, DeLyle Manwaring, and myself, we'd like to welcome all of you to this webinar. I think one of the things that we're excited about is really talking through how working together between hospital systems and our providers and our payers, we can really bring a enhanced level of care and an improved quality for our patients. So as we live today in a obviously evolving healthcare world, we recognize this word transformation showing up everywhere. And in fact, in a country today where we spend 20% of our gross domestic product on delivery of healthcare, we do need to transform our healthcare system. Healthcare inflation continues to go up every year at a rate of about 4%, and we do need to bend that cost curve significantly. And while we bend that cost curve, we don't want to compromise on the quality of care that our patients expect and deserve, and we want to make sure that experience continues to improve over time. In the United States today, interestingly enough, close to 40% of healthcare systems lose money on the delivery of healthcare. In fact, when you look at operating income for some of the large healthcare systems that do get reported through Modern Healthcare and other organizations around the country, you might see really high numbers. Now, keep in mind that many of those numbers also take into account investment income for those large healthcare systems. But the delivery of healthcare itself is not necessarily a large money maker for most hospital systems around the country. Musculoskeletal care does tend to be a large money maker, but it's frequently offset by other areas that are not nearly as profitable in the healthcare hospital environment. Looking at some of the healthcare industry trends that I think are important today and will continue to play a big role moving forward, I'm just going to touch on them now, and then we'll go into them in more detail here throughout the presentation. First of all, the term healthcare consumers is starting to replace the term patients more and more. And that's because in many cases, the term patient is really associated with sick care. And we're trying to now move our healthcare system to start thinking in a more evolutionary way around well care. Just as we all likely utilize apps like Amazon and Netflix, we're all looking for anytime, anywhere solutions. One of the beauties of Amazon is if you have something that you want to buy, you can jump on your phone or on your computer. You can place the order right now. It's all done digitally. And by the time you get home, many times it's waiting for you there. That immediate satisfaction is something that on the consumer side, from an industry perspective, has become very common, but in healthcare continues to lag behind. Patients deserve and expect a seamless experience when they are in fact coming into contact with their healthcare provider and their healthcare systems. This is without a doubt something that we have lagged as a industry, but something that we need to make more of an effort around. And then finally, the fact that personalized treatment for better outcomes is an absolute key. It is not a one-size-fits-all world, and in fact, there are better things that we can do for individual patients that are specific to them. So let's talk a little bit around wellness and the idea of the consumer. So, in the old model, healthcare has always been around treating problems. You wait until you got sick, you went to the doctor made you better, the doctor got paid for that care. In the new model, healthcare is now more and more about maintaining well-being and improving quality of life. So it's not just about taking care of the sick patient, it's really keeping that patient from getting sick to begin with. If you look around the country, there are massive disparities in terms of where we are with well care. In fact, if you look across the state, for example, just the state of Florida where I live, the very southern bits of Florida are very much attuned with the idea of well care and keeping patients out of hospitals and out of the offices of specialists through the high attribution towards Medicare Advantage plans. As we go further north into Central Florida, we see that those Medicare Advantage plans and the managed care organizations drop off very dramatically, and we still have more of a focus on sick care, interestingly enough. In the old model, the idea around the consumer was that everyone had the same need, which was to be healthy. In the new model, we're recognizing that different patients have different definitions of health. So, for example, if you're born or with type 1 diabetes, or you end up with type 1 diabetes as a child, your definition of healthy is really making sure that you don't end up with diabetic nephropathy, making sure you don't end up with peripheral neuropathy, making sure that your cardiac system remains healthy. Very, very different than somebody that has really lived a life until the age of 70 or 80 with minimal health issues at all, who may define their health very differently. When we talk about anytime, anywhere solutions, the idea around expertise trumping convenience, which was the old model where patients were ready and willing to wait, weeks or months to see a specialist, today is leading more and more to the fact that people want to use technology to get high quality advice. I can tell you, I'm an orthopedic surgeon. It's very rare to me today to see a patient that hasn't been on the internet, seen an example of what a total knee replacement looks like or a total hip replacement looks like, and is asking much higher level questions because of the increased knowledge that they have about their procedures and around their illnesses. Again, looking at kind of this idea of connection, disconnection, in the old model, the caregiver relationships were expected to be long-term and fixed. Today, mobility and shifts in coverage make these relationships more transient. Now, again, it doesn't mean that the focus on primary care and a gatekeeper model or a specific clinician quarterback isn't important. In fact, quite the opposite. It's very important. But today, patients are in fact more willing to shop for the right provider for the care that they have today and the needs for that care that they have today. In terms of experience, the idea of healthcare being defined as episodic visits and the bedside manner of doctors is really changing, in that what patients are looking for is more of a team-like approach, and recognizing that the ongoing relationships with their healthcare provider extends to the staff, the nurses, the assistants, and frequently to technology, where much of healthcare can be provided just over a cellular phone, incredibly enough. And this idea of empowering the individual, where historically the physician was the final authority on healthcare matters, has really changed, where a physician today is more and more of a service provider, and patients tend to own their healthcare in a much more significant way than they did in the past healthcare models, which again are very interesting. Then finally, this idea of radical personalization. Today, it's not enough to know that if a patient is diagnosed with stage 1 breast cancer, what 5-year survivorship rates are. They want to know, well, for this specific cancer, if it's stage 1 and it's this particular type of cell that we're seeing predominantly, and given my age and my health level and my comorbidities, what is my risk? And given the genetics of this tumor, what is the best chemotherapeutic regimen for me? This idea of radical personalization, both in terms of managing expectations and in terms of managing outcomes, is not only necessary, it's deserved. We as healthcare consumers deserve that level of personalization in our medical care. And this search for authenticity, I think, really ties in very nicely to that, in that people are in fact expecting their healthcare providers to be honest, decent, ethical, moral people. Again, we deserve that, and I think patients rightfully should be able to expect that in a meaningful way. So let's just talk here about some of these things in a little bit more detail. So historically, the old assumption was that healthcare was based in the clinic and the hospital. And I want to be clear that although the clinics and the hospitals will continue to be extraordinarily important as we move forward and we evolve our healthcare system, healthcare without a doubt is happening everywhere around us. Again, as I mentioned, even through our cell phones. Medicine, which had historically been seen as an exclusive, highly regulated club, where you had to be a large multi-billion-dollar organization to get in the healthcare space, can now be disrupted by new services and empowered users in a very meaningful, out-of-the-box way. And again, historically, the hospital, which has always been the primary customer for medical products and services, has moved, and it is the patient, that healthcare consumer, that is now becoming the customer. And because of high deductible insurance plans, tends to shop for their care in a much more meaningful, thoughtful way than they ever did before. So as we start thinking about how we refine our focus around making sure that our healthcare consumers are in fact getting the very best care, it becomes more and more important that we as providers, both as a physician and a hospital system, recognize that we can transform healthcare together in a much more meaningful, long-standing way if we work together and we focus on our patients and on our engagement and on our research. How do we do that? Number one, this is all really founded upon an exceptional customer, or in this case, patient experience, making sure that we're focused on patients in terms of improving their outcomes and giving them a differentiated, highly impressive experience throughout their care, engaging with them, delivering on those expectations, delivering on their needs, and delivering on their preference. And then finally, doing research on what we're doing so that we can design, plan, and innovate around providing the very highest quality of care for the very lowest cost. As you start reading some of this and understanding some of this, you're starting to think more and more that a lot of this is really around hospitality. It's not only making sure that the patient remains healthy or gets access to the very best care, it's also taking care of the hospitality expectations that they have as well, and creating that differentiated experience throughout their care. So this can obviously seem very overwhelming. How do we do all of these things around our patient care? How do we start to redesign the care that we have historically provided in a very efficient, thoughtful way? Well, the way I think about it is very simple. True north remains true north in healthcare, and that true north is very nicely described by Michael Porter at Harvard Business School. Is all around value. It's how do you improve quality, improve access, and decrease cost. If we can do that in a meaningful way, then now we start becoming a real meaningful part of the solution in healthcare in terms of delivering high quality, differentiated experiences, high quality outcomes for our patients, but doing it at as low a cost as we can to help meet our societal needs in terms of reducing the cost of care. So when I think about this idea of the quadruple aim and patient-centric healthcare, to me, it's really pretty simple. It's improving the patient experience. It's thinking about it not only from an outcomes perspective, which again, I would argue is foundational, right? At the most basic foundation, we have to be good at the care that we provide, but can we do it in a way where the patient has an outstanding experience? How can we also improve the clinician experience, right? Clinicians that are coming to a hospital or going to an ASC or taking care of patients through a telemedicine platform, how can we make their experience also positive? And then taking these two things together and applying them across an entire population to improve the health of a population and the health of society as we know it today, and doing that while we simultaneously reduce the per capita cost of care. The good thing is we know that high quality care consistently ends up costing less. It costs less because we decrease complications, we decrease readmissions, we decrease return to the operating room, we decrease infections, we decrease poor outcomes, and all of those things end up leading to lower costs. So this never-ending astute focus on quality in healthcare is something that we can never put aside. It's interesting, you know, having been able to bridge the gap a little bit between provider and healthcare executive. It's interesting to me when I think about what are important to providers and what are important to hospital leaders or healthcare leaders, and how much of it overlaps. And as it turns out, if you look at these two circles and you look at the things on the hospital executive side and then the various factors on the provider side, I would imagine that most of you would say, well, I'm really interested in things on both sides of these circles. And in fact, the overlap is dramatically greater than what many of us give ourselves credit for. And I think that is, in and of itself, a massive opportunity to right this ship in terms of the relationship between clinicians and hospital leaders. In fact, I was speaking this past weekend at the American Association of Hip and Knee Surgeons, and we had about 150 people in a business course that I was talking at, and I asked everybody in the room, how many of you do some procedures in a hospital? And of the 150 people, probably about 140, 145 of them raised their hand. And then I asked, how many of you feel like you have a great relationship with your hospital administration, that you work very well together? The shocking thing was only 3 hands stayed up. To me, that's an opportunity. It's an opportunity to bring our providers and our hospital leaders together to create that differentiated, high quality, high touch experience for patients who in the end are in fact our consumers and do give us the opportunity to provide that higher quality care in a more enhanced environment. So how do we bridge that gap? How do we provide better health care and do that in a way that lowers costs? And these 6 principles, I think, are very, very clearly aligned. Number one, you need a sustainable rate of growth, which we have. We need to be able to measure performance, which most organizations, most practices still don't do very effectively, but it becomes, again, foundationally important to do that. We do need to share responsibility for health, and in many cases, that responsibility, that shared responsibility, can lead to enhanced payments through shared savings plans. We need transparency in price and in quality. It's interesting that we talk about transparency in price, but only recently is it becoming necessary. Only recently do we start having the tools to start to be able to compare based on quality outcomes in an objective, measurable way. We need best practices around clinical care paths so that we can coordinate care in a meaningful way. And we finally need to start paying appropriately for outcomes and health. One of the ways that we can start doing that in an effective way is through the creation of clinically integrated networks. And these networks allow us to start bringing together hospitals, providers, and payors all together in a very meaningful way. The way that I would suggest that this starts working very effectively is as you start looking today at where hospitals sit in the methodology of where volumes are done for total hip and total knee replacement, for example. They have historically seen the very highest volumes taking place in the hospital. As hospitals now are being surrounded by ambulatory surgery centers, more and more of the volume is moving to the ambulatory surgery center and in fact leaving the hospital. That decrease in cost because of the volume moving to the ambulatory surgery center has historically benefited the payors only. Through the creation of a clinically integrated network, that cost can now be shared with the providers, with the hospital, and with the payors in a very meaningful way, so that everybody is really benefiting. Delisle, for some reason, I'm not able to forward anymore. Why don't you try on your end, if you don't mind? Great. So here's an example. Here you've got the hospital in the middle. You've got the ASCs around the outside. As the hospital volume starts to decrease over time and the volume moves to the ambulatory surgery center, that savings is then, which is generated, is able to be shared back with all of the players that are participating in this process. And that is through the clinically integrated network, which I mentioned before. With that, I'm going to turn things over to my colleague, Delisle, who will share with you kind of how we do this and what kind of infrastructure we need to actually pull this off.
Thank you, Will, and thank you for those, that introduction as a whole. And for those who do not know Will, he does speak with authority in the subject, being not only a nationally known, world-renowned orthopedic surgeon, but also a former Cleveland Clinic executive that is now working with HOPCo to help physicians' practices as well as payors and health systems really drive this home on a daily basis. So as Will indicated, I'll talk more about the actual how, where the rubber meets the road and where we're able to actually make a change. And so in order to be able to do this within your health system, your practice, or really in any market that allows you to transform, there's 4 fundamental and base components that are needed. One being obviously systems that provide you not only the data, but the information needed to be able to have at your fingertips to transform ideologies and maybe practice patterns, but also just the normal, whatever you're doing today, issues that there may be there. You also need true people that are able to truly dig into and help lift and change the culture as a whole. Standards, which include both protocols, pathways, care sets, and order sets that allow you to truly streamline the process from the clinic all the way to the discharge of the patient from the clinical care. And then lastly, a structure that's proven to be able to facilitate the actual work and ensure that the work gets done in an orderly and efficient manner. So with that, I'll walk through some examples of every single one of these individually, starting with those systems, all the way from provider engagement systems, patient engagement systems, specific quality scorecards, KPIs, both clinical and operational, finance, etc. You can look through this slide as a whole, but the reality of these systems is they need to be as real-time as possible. As everybody probably knows here, within healthcare, that's relatively difficult. However, having the systems to be able to pull, aggregate, and display the information in a meaningful way in any one of these areas that you see here on the slide are vital to be able to truly transform the culture and really make an impact and a difference as a whole. Just 1 or 2 examples of this that we have is the operational and clinical metrics and KPIs here that allow you not only to drill down, but to also benchmark and look at where you compare to across physicians, across hospitals, across a clinically integrated network, and even how you compare nationally as well. Another opportunity is being able to do this with the population health data as well, this being some bundle payment information and being able to again see where your discharge disposition may look, where your home health visits are, and even readmissions, etc. But having this data is obviously important, but having it in a structured and benchmarkable structure is really what allows you to change culture and really make everything that Will just mentioned a reality. Secondly, the people. So we see from myriads of different health systems and payors and clinically integrated networks across the country the need for true integration of not only people on the ground, we like to call them boots on the ground, that are leading the effort. May they be surgeons, executives, or administrative work, including advanced practice clinicians, analysts, even case managers. But then those individuals, and this is an important piece to it all, is to really have key experts as support staff, really making the difference in providing the bench strength and the bandwidth needed to be able to provide these services and really dig in totality. The next piece is the order sets and clinical pathways and patient education. A lot of health systems out there right now already have, within musculoskeletal, developed a lot of order sets and clinical pathways, but are people actually using them? And I say that from both the clinician side all the way to the case manager, physical therapist, etc. Utilizing these care sets and clinical pathways truly does minimize the variation and improve the overarching value, as Will mentioned before. But adhering to them is what we have seen is incredibly important. We are able to track the compliance to the utilization of these order sets throughout the entirety of the care continuum, and recommend highly that anybody who is working with these to be monitoring them and having one-on-one conversations with whoever it may be, from the surgeon to nurses to even OR techs. Make sure that everybody is truly utilizing them. We also recommend, if you do not have these, just start with basic templates and use those templates as a starting off point where everybody within the care team can start the discussion of transforming the care one patient at a time. Next, the structure. There's a multitude of different proven governance structures that can be formulated to really ensure that the work of all of this is systematic and is getting done and working through all of the different pieces of this. We like at HOPCo the joint venture approach, which allows for a board type of mechanism where individuals from the health system, as well as the physician groups, and you can even add in vendors and or payors to that board. But by doing that and allowing that structure, there is more of an aligned mechanism through all of those stakeholders. And all those stakeholders have skin in the game in making sure that the work proceeds efficiently and effectively. And as Will mentioned before, they're more aligned together in making sure that everything happens the way that it should. Other participants, support staff could include, clinical leadership, operational and service line experts, and even payer experts, case managers, etc. But similar to the previous slide that I mentioned, we do believe very strongly and have seen the benefits of having strong surgeon leaders as well as administrative leaders together in a dyad approach to be able to really take the mantle of this work and push it along in an effective manner. And speaking of effectiveness and efficiency, we very much are proponents of using project management software to help the work. So much of this is detail oriented, but so much gets falls through the cracks and never gets really finalized at the end without knowing who said they were going to do what by when. And it truly elevates the accountability of the work when everybody can log into these systems and see who did what and who said they were going to do what. Very minor and something that many people overlook, but we have found over time essential to be able to make sure these robust programs are effective. And then lastly, physician incentives. In working through these, we have found that there's really two components to ensure that the physicians are aligned, but are also a part of the team in making all of these changes and improvements. There's the two buckets are either one, from the hospital side, which can be provided to the providers on a legal basis based upon helping the hospital improve the overarching quality of the program. And those are usually $30,000, maybe even upwards to $50,000 potentially a year that can be paid. And then secondly, from the clinically integrated network, there's additional savings that can be provided to all participating providers based upon the savings generated from the clinically integrated network. And we have seen those savings upwards towards $70,000 to $80,000 a year that can be provided. Now, you take both of those and you combine them together, and you can see very quickly how those incentives become very meaningful, even for very busy orthopedic surgeons in their practice. Now, obviously, all of this needs to be reviewed by third-party valuation companies and really reviewed by attorneys to make sure that everything is legal. However, we have seen these over and over again be determined as such and are very much doable across the nation. So with that, I'm just going to shift gears a little bit, and with my remaining minutes, just talk through some of the case studies that we have seen in working with health systems and payers and providers across the country. The first is really aligning multiple practices and working with practices to truly transform and improve the hospital operations, which is denoted here through a contribution margin improvement year over year. This hospital started their program in 2016 and frankly already had a very, very strong program as a whole. We anticipated in bringing this program to this hospital that there would really only be maybe 8 to 10 providers that would want to aggregate and shift their practices to more align with this facility through or due to the clinically integrated network and the operational improvements that we were planning. Ironically so, those 8 to 10 providers actually became 32 throughout the years as more and more providers heard of the excellence in clinical care and patient experience, but also were receiving the improvements and the savings generated in the clinically integrated networks. So 32 providers all in all ended up coming to this hospital, and that contribution margin increased year over year. And again, using contribution margin, you can understand that not only did net revenue increase just due to total volume increase from 10 surgeons to 32, but also the operations and the finances improved as there was better throughput and patient experience as well. Second case study, this was actually from a specialty hospital, which was a hospital within a hospital. So using excess acute care capacity within one acute care facility, we designated out a portion of the ORs and also the floor to really be specific to musculoskeletal care. And in that, we saw a 14% increase in volume just year over year, a significant 14% increase in net revenue. But when you even take into account the inpatient, outpatient change in revenue, that it would have equated to 22% as a whole. And then that adjusted contribution margin significantly up as a whole. And all of this was done despite the change in inpatient revenue based upon the change of the inpatient outpatient only list, and despite COVID as well. Lastly, on the CIN and the work that Will talked about, the overarching opportunity, we were able to see an overarching savings of $32 million with an annual run rate year over year. So the program launched at one point, and education began with providers. Signing the providers up into networks began, and the real work of true population health began. And as you can see over that 24-month period, the trend, which represents the total spend year over year, which was at 13% at the beginning, actually went negative to a negative 5% trend year over year. And this really symbolizes the opportunity as a whole that payers, providers, and health systems have in totally transforming the population health management of musculoskeletal in their given region. And this is done through multiple disparate competitive groups. This the savings that I just showed was done through a lot of community orthopedic surgeons. 49% of all of the providers were from a multitude of different groups. Some were managed by HOPCo, and then some were also managed by the hospital. And so the beauty of this program and what we've articulated today is it can be done not only with employed surgeons, but community as well. And we went ahead and took those results and had a third party. Many of you may be familiar with Clarify Health, but a third party organization that looked at the quality indicators between everybody, all of the surgeons in the clinically integrated network, and those really managed through this CIN. And as you can see here, from the episode cost to the skilled nursing facility and inpatient rehab rate to mortality rate, on each one of these indicators as a whole, those working together within the CIN were able to achieve the superior results as a whole. So with those as really case studies and helping you understand really the opportunity as a whole for you, your organizations, we want to pause there and be able to open it up for everybody to be able to take questions that you may have.
Yes, great. Thank you both so much for that presentation. And as Delisle mentioned, we will be taking questions now from the audience. So audience, please submit your questions in the questions pane. And if we don't have time for your questions, HOPCo can always get back to you after the webinar. Alrighty, so first audience question, and this is for you, Will. How does the consumer learn about expenses, costs associated with procedure as it varies from one healthcare team to another? And also, how could a hospital assess the actual cost and potential profit?
Hey, two good questions. So we'll start with the first one in terms of, price transparency. Now, this is one thing that Congress has really tried to focus on over the course of this last year and this coming year, forcing more price transparency with hospitals around care. I think over time, this will be a much easier methodology than what we have today. Today, generally speaking, if you are going to have a procedure done in a hospital or at an ASC, I would strongly suggest meeting with the financial advisor. Every hospital has one. They're actually obligated to let you sit down with them so you can, in fact, get a sense for what your true out-of-pocket costs are. They obviously vary for everybody, depending on whether you're in network or out of network, depending on whether you're having your procedure done in a hospital-based outpatient site, a freestanding outpatient site, or inpatient. All of these things clearly make a difference. And then finally, depending on the particular benefits plan that you have, if you have a so-called Cadillac plan, or if you have a high deductible insurance plan, it's different for everyone. So sitting down with that financial counselor and really having an idea of what your costs are is an absolute key. The second comment that I would make is really around hospitals and how they manage expenses. You know, one challenge that many hospitals deal with, actually all hospitals deal with, is that hospitals are a very high fixed cost entity. You have very high costs in terms of, you know, staffing an operating room, staffing having equipment to do surgical procedures. The construction guidelines for building a hospital are extremely strict, right? It's expensive to build a hospital. On average, you know, you're usually spending anywhere between 1.2 and 1.5 million dollars per hospital bed in a hospital setting. So your fixed costs are high. You know, it's important to start when you think about procedural volumes and how that helps cover your expenses. It's important to divide your expenses in terms of your fixed expenses, your variable expenses, such as the use of an implant or disposables or PRN staff, which adds on to a particular cost. And then finally, contribution margin. So once you've covered all of your expenses and you can do another procedure, how much of the reimbursement from that procedure drops to EBITDA, drops to profit, versus how much of it continues to cover your expenses. So lots of financial tools on kind of how to do that well. Cost-based accounting is frequently used for people and for trying to divide out costs from EBITDA, from contribution margin, but lots of tools on the finance side to do this efficiently and effectively.
Great, thank you. Okay, another audience question, and this is for you, Delisle. How were you able to get orthopedic surgeon engagement?
Really good question, and one that you know, I would say is difficult at times. But the beauty of this program, and that, you know, the structure that we outlined here, is that it creates a vision and a roadmap for the future that a hospital administrator or, you know, service line administrator or whomever it may be can lay out in front of an orthopedic surgeon. I have the privilege of working with orthopedic surgeons every day of my life, and I have been able to prove day and day again how truly motivated they are to improve and help the patient in every way, which way that they can. But often the barrier there is the lack of roadmap, lack of, you know, total vision to where how to do it. And frankly, to be fair to those surgeons, administrators come and go often when they are there for the long haul in a specific community, building a you know, multi-decade practice. And so having a roadmap and being able to articulate that has made all the difference in truly getting their engagement and bringing them to the table for the long haul. As they see that, they see the opportunity, but they also see that it's not just the flavor of the month or the flavor of the administrator at the given time. And so I would just submit that that is one very important aspect, and one that has proven time and time again to be effective in truly being able to engage them. I will say, secondly, obviously having those incentives available to truly not, help them pay for their next boat or daughter's tuition, but actually compensate them for the time that it is going to take them to be a part of that. And I think that that's an important point for everybody to really internalize when you think about how currently medical directorships out there are relatively insignificant when you look at total compensation for, say, an orthopedic surgeon or a spine surgeon, etc. But when you look at those incentive opportunities that I presented earlier, you truly do see some significant money on the table, again, to compensate them for the massive amount of work that it's going to take for them as well. And so those two coupled together, frankly, I have not seen an orthopedic surgeon who is not engaged when we bring both of those to bear and bring those to them in a well-articulated and compelling argument.
Great. Very interesting. Okay, another question. How can we better align the needs of the clinician with the needs of the hospital? Will, can you start us off with this one?
Yeah, so I would say the first comment I would make is recognizing how much clinicians and hospitals have in common in terms of their desire, right? Number one, every orthopedic surgeon, neurosurgeon wants rapid turnover times, wants their sterilized instruments to be, to not have holes in the wraps and to not have to be reflashed, wants on-time starts to occur, wants their patient to have highly specialized care from the nurses, from the techs, from the anesthesiologist. So all of those things I think are clearly there on the clinician side. When you think about it from the hospital side, hospitals have no reason to want anything different than that. The challenge on the hospital side is when you're footing the bill, it's sometimes difficult, very candidly, to have a dedicated group of orthopedic nurses that don't do anything else, or a dedicated group of orthopedic anesthesiologists that don't do anything else, because it becomes by definition a little less efficient when people aren't floating to other services. So I think that there's kind of a happy medium to have that differentiated experience for patients and for clinicians in a hospital setting, but at the same time to do it in a financially thoughtful, responsible way, so that from a hospital's perspective, they're making up for some of their added costs through hopefully an increase in volumes, because clinicians are seeking out that differentiated experience which a hospital is choosing to provide. If you look, Maria, around the country, highly specialized sites for care clearly provide gold standard care, right? I mean, when you look at the Hospital for Special Surgery, which is a hospital that is committed to musculoskeletal care, it's differentiated. The Cleveland Clinic, cardiac care, they essentially run a hospital within a hospital for cardiac care. MD Anderson for cancer care. If you look at some of the sites that we're involved with at HOPCo, up in Jacksonville, there's now the Performance Orthopedic and Specialty Hospital, which is a hospital within a hospital at St. Vincent's. The patient experience and clinician experience scores are phenomenal. In fact, that hospital right now is working at capacity. How many hospitals can say that their ORs are at capacity? That's pretty impressive to be able to say that. So highly differentiated care, without a doubt, has been shown over and over to lead to better outcomes, lower costs, and higher experience. So the alignment is there. It's just sometimes a matter of getting the two groups to talk candidly with one another and almost have an intermediary that can create the infrastructure to make it successful.
Well, that's a great segue to the next question. So who should take the lead when trying to align clinician, executives, and payors? Delisle, can you start that one?
Would love to. Whoever has the ultimate vision and knows of the opportunity. Another way to say that, and probably a better way to say that, is if you get it and you get the opportunity, you lead it, and be the leader and lead towards this end game. I think that there's no reason, may it be a payer or a health system or one surgeon, for any one of those stakeholders to sit back and to wait for anybody else. The true opportunity is so vast and so great, and frankly, it's right now in front of us all. And so the time frame to lead is now in really moving the ball down the court as fast and as efficiently as possible. So we have seen across the country that any one of those three stakeholders can effectively take that and move it towards that transformation. It doesn't take one or the other. No one of those is better than the other, but it takes leadership, and it takes putting your neck out on the line to really start pushing that ball down the court. Will, would you add anything to that?
No, I don't think so. I think, the one thing I would maybe just comment on is there are the obstacles that exist in bringing the groups together tend to be fictitious and based sometimes on old negative experiences. And I would say that if both groups are really committed, the clinicians and the hospital leadership are really committed to creating a differentiated experience, sometimes you've got to kind of start fresh, and you got to just say, look, whatever, I know I asked you to buy this piece of technology and the hospital leadership said no, and I've always been upset about it. You got to kind of put it behind you and move forward in a positive way to create something that is in fact transformational.
Brilliant comment. I mean, you have to put the past experiences behind you for sure to be able to lead that and move forward. Great point.
Great. All right, next question. How can hospitals remain sustainable as cases continue to migrate to the outpatient setting?
Yeah, so I can maybe start on that one. So I think a couple things. Number one, hospitals obviously deliver a product that nobody else has historically been able to deliver in an inpatient setting, right? I mean, what a hospital does versus a SNF versus a rehab facility versus, a patient-centered home, surgical home, or medical home. There are some times where you just need a hospital. So the first thing I would say is you have to understand your market and how many hospitals you really need in your market, and how many hospital beds you need in your market. So I'll tell you something that I'm not sure will be terribly popular with some of the hospital leaders on the webinar, but this is the reality. The United States is overbedded by about 40%. We don't need all the hospital beds that we have today. That essentially means that the most successful hospitals that can provide a service that patients seek because they're healthcare consumers will survive, and those that are not living up to that promise of outstanding patient experience may not survive. COVID actually led to the closure of many hospitals around the country. If you had a real deep connection with your local community hospital and it closed, that can be heartbreaking for patients and terrifying for patients. So the first comment I would make is we are overbedded and some hospitals will be challenged. That's number one. Number two, recognizing that the traditional ratio of operating rooms, intensive care unit beds, and ER beds, and acute care hospital beds is changing. Today, we need fewer hospital beds for the number of operating rooms that we have, because even when you do a procedure in an inpatient hospital, the reality of it is the likelihood of that patient staying a shorter duration than they would have stayed 10 years ago or 15 years ago is very high. So not just in orthopedics, but in gynecology, in general surgery, in bariatrics, in cancer surgery, more and more patients stay shorter length of time than they did in the past. So that's the second thing. The third thing is, I think, to start thinking about how do you partner in a vertically integrated way with clinicians and with payors in your community. And if you start doing that, you start thinking less and less about how do I keep filling my hospital with patients, and start thinking more and more about how do I fill my hospital with the right patients. And that is a difficult question for many folks to ask, especially in an environment that is in fact overbedded and has too many hospital beds today. So to some degree, I think that the question will kind of answer itself based on, you'll survive if you're really, really good at what you do, and you might not survive if you're not really good at what you do. But I think that there are tools to create those differentiated experiences that allow you to be the best in your community. And in some cases, it requires partnership.
Okay. Delisle, anything to add?
Yeah, I would just add that there's a misnomer out there. Everybody seems to be talking about the shift to outpatient within MSK, and that the hospitals are going to be irrelevant. I think, Will articulated well why we may be overbedded, we may need less total beds. However, we still need acute care facilities for musculoskeletal cases. And that's well beyond just even the trauma. I like to give the example of my grandmother, 80 plus years old, is not ever going to have her knee redone in an ASC due to her comorbidities, and frankly, the lack of really knowing how she's going to do with the procedure and actually post-procedure. Now, she may discharge same day from an acute care facility, or even within 24 hours of having that surgery. However, she's just not a good candidate for an ASC. Mm-hmm. And so everybody ends up talking about the large increase of cases that are going to be done in ASCs, and we totally agree with that. However, it's starting at a very low end. So another way to say it is 100 ASC total knees, and adding another 100 is, on a percentage basis, a very high percent, right? But it's still only 200. And it's important to note that the advisory board themselves have noted that in the coming decade, hospitals will still see an increase of even actually 9% of orthopedic musculoskeletal related cases in the future now. So this misnomer that is being talked about, I just want to underpin, don't count out the acute care facilities for MSK, even in the short or even long-term perspective.
Great. I think we have time for one more question. Can you describe the infrastructure needed to achieve a negative trend in MSK spend?
Will, do you want to take that?
Yeah, I can start. So it's not easy, that I can tell you. That example that Delisle shared was 114,000 Medicare Advantage lives. That was in Arizona, Maricopa County. To do that, you really need almost an insurance infrastructure with your organization. So hospitals, for example, that have an insurance company connected to them, utilizing that infrastructure can certainly be very helpful. At HOPCo, for example, we employ our own actuaries. We have several ex-insurance executives, including the ex-CEO of Aetna for the Mountain States. We have one of the founders of CareMore that works for us. We've invested about $100 million in a claims analytics platform that is proprietary. We've built it, and it allows us to look at claims data to ensure that the claims data is in fact correct, that we're taking risk on the right patients, that the procedural codes and the diagnosis codes are correct. So it does require that work. That once you have that data, you then need to transparently show it to the decision makers. So you have to have a clinically integrated network that includes clinicians who are looking at that data and making changes to their clinical practice based on peer-reviewed, data-driven clinical care guidelines, and then hospital systems that also are being transparently sharing their data in terms of how they can get better. So, you know, you really need to be vertically integrated so that every single piece of the pie here, every domino that's involved in the care of the patient is in fact committed to getting better. You have good data. That data is shared through dashboards, through, you know, transparent methodologies, and then incentives are being paid to everybody involved in the care of that patient to make sure that they're committing the time, they're committing the resources, and in fact they're being rewarded for the outstanding care that they're providing.
Great.
If I could just add, I know we're at the top of the hour, but I'll just add, and you know, those people and that infrastructure can't necessarily just be general, you know, population health management. What we have seen is, you know, payors to health systems have hired us, HOPCo, as MSK experts, and having really the expertise in the 26,000 ICD-10 codes that are associated with MSK is really, really important. So I would highly advise that anybody, you know, going down this path really look into and interview very well. May they be building it in-house or, you know, looking to an exterior entity to help, to really dive into their expertise specific to MSK, because it truly is its own different world.
Okay, thank you. Thank you both so much for your time. That takes us to the end of our webinar. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey. We'd like to once again thank the sponsor of today's webinar, HOPCo. For more information, please visit hopco.com. This webinar will be available on demand, and a link to a recording and the PDF of slides will be sent to webinar attendees within the next 48 hours. This concludes today's presentation. Have a great day.
Thank you.
Thank you, Maria.
Thank you.